So this is sticking with the primary endpoint. This was the data before the trial. In fact, you know, if you're really interested in statistically significant results, there was one there before we even started. But I didn't believe this big treatment effect. And now we've got, these are the trials that have been done afterwards. There was our trial and another reasonably big, not as big as ours, but about 1,000 patients from Washington got the same result. And if you add these two together, but I'm not adding them with this because I don't trust small trials, but if you add these two together, you get that. It's no different. It is actually statistically significant at the less than 0.05 level, but it doesn't make any difference. The results were just the same without it.
So is that, diagnosis guideline is worldwide the same? I mean, the GCS3 unconscious patient part, they do.
At the moment, these results are just, people are trying to figure them out and make guidelines along the way. So that process is ongoing. So, but coming back, sorry, Masafumi.
Oh, thank you. I'm very curious about your wording in the conclusion section. You said TXL reduces bleeding death.
Reduces?
Bleeding death. Head injury related death.
Head injury death.
Yes. So it's very assertive expression that your primary analysis was not significant, but this meta-analysis was significant. And I'm very curious why Lancet editor permits to use that very assertive expression in the conclusion. Can you understand my question?
Yeah, I can, and it's because I had a big debate with the Lancet about it. I said this dichotomization of results into positive or negative is an abuse of medical statistics. That's what I believe. And I managed to convince the editor of the Lancet that that was the case. The fact that the American Statistical Association agreed with me did help a lot. And the fact that 800 statisticians have written an article in Nature saying that we must stop dividing results into statistically significant. We must stop even using that phrase, right? These two words joined together cause so much damage, and they don't mean anything. That it's an excuse to stop thinking about results. You know, this trial contains information, and information is continuous, and we have to understand it in all its continuousness. We mustn't say this is statistically significant, that's not statistically significant, therefore you can't say it reduces deaths. The reason that I think that you can say it reduces deaths is because the best estimate of the treatment effect, which is the point estimate, suggests that it does. You know, and you know, it could be a 10% reduction in the risk of death, it could be a 20% reduction in the risk of death, it could be hardly any reduction in the risk of death. But it's still, the best estimate is that it reduces the risk of death, and we should be allowed to say it irrespective of the statistical, of the p-value, or wherever if p-value is on this side or this side of 0.05. 0.05 is completely arbitrary. Where did it come from? Where did it come from? 0.05. Why is that so important to you? You're blaming Sato Sensei. In fact, hang on. This is quite nice here. This is the way the American statistics. It says, why do so many colleges and graduate schools teach p is equal to 0.05? And the answer is because that's what the scientific community and journal editors use. Why do so many people still use P? Is it because that's what they were taught in college or grad school? So it's just like, it's just part of history, and it just keeps on rolling on because people believe it, you know, people believe it's right and they do it and it just carries on. But I think we've just got to get away from it. We've got to, it's not helpful. And I think it's causing more problems because this is, so there's a group in the UK that looks at trial results and makes policy, and you know, the experts on the guidelines committee think it's essentially a negative study. There was no significant improvements. Everybody's doing it, you know. Everybody's doing this negative, positive thing with results. So, right, coming on to your point now, you hypothesized that the treatment would be more effective in patients with less severe injuries. And so that's what we did find. So in patients who had mild to moderate head injury, there was quite a large reduction in the risk of death. But in patients with very severe head injuries, there was very little reduction. There was no reduction at all, in fact, you know, minuscule, tiny, but no evidence of any reduction. So now we're getting more complicated, you know. Now we're having to look at the results and try to think, we're trying to get the meaning out of the results, you know. So in patients with mild to moderate head injury, there was a large reduction in the treatment effect, but not in patients with severe head injury. In patients whose pupils react, there was quite a large reduction in the treatment, in the risk of death, but not in patients whose pupils did not react. So now we've got to think, well, maybe, you know, is this, you know, you made a hypothesis, you thought the treatment, you know, it's a very plausible hypothesis, you know, and there's some evidence here that supports it. But it's more complicated than that, in that in severe, if I go back a slide, patients with severe head injury didn't seem to do very well, but this is not a pre-specified analysis. This is an exploratory analysis. That's why I've got this big warning sign down here. In high-income countries, there was some suggestion that patients with severe head injury did better, but in low and middle income countries, they didn't. Now maybe that's a statistical artifact, but maybe it's real. So we have to start thinking about the results, you know. We have to start to think, well, what's going on biologically inside this, you know, in this trial population? So we can see some interesting things here. In low and middle income countries, the death rate is much higher than in high income countries. Yeah? So, you know, there was 37% dead compared to 21% dead. So, you know, many more patients die in low and middle income countries. You know, poor countries, a lot of the patients were recruited in Pakistan. And I've been to hospitals in Pakistan. They're not like hospitals in Japan. They're very simple.
So in this study, the brain hemorrhage is only in the inside of the cerebellum, or is there
It could be any
SAH or something like that.
Anywhere.
In the case of the SAH, open the head bone or some drainage or something like that. But in that kind of things cannot be properly done.
They can do neurosurgery. They do have neurosurgeons, but they don't do very sophisticated neurointensive care. So I'll keep on going. So we thought that the treatment would be most effective when given early, and we saw this very strong time to treatment interaction in patients with mild to moderate head injury, but there was no evidence of any time to treatment interaction in severe head injury because there was no benefit. You know, if there was no benefit, then how soon you give the treatment doesn't really make any difference. But where there is a big benefit, where there is a benefit, and it's quite big, you know, the earlier treatment is better. So this is this is a sort of something that this is a way to explain a concept, right? And it's about null bias in randomized trials. And I think it's a big problem in head injury in particular. And this is my way of explaining it to clinicians. I know statisticians could get it in a very complicated way, but in a randomized trial, in our big trials, basically, you know, the relative risk is the risk of death in those who get the treatment divided by the risk of death in those who get the placebo. Now, in big trials, you know, if you randomize 20,000 patients, you get the same denominator in both groups. About 10,000 get the treatment and about 10,000 get the placebo. And so you can just sort of cancel out the denominators. Just, you know, to make things simpler, the relative risk is just the ratio of events in the treated group and the untreated group. So if you divide the number of events in the treated group divided by the number of events in the untreated group is the relative risk, because the denominators cancel out.
So what the relationship with R square and relative risk, mathematically?
I don't know. I don't want to go into it. It's not a question for me, it's a question for some statisticians afterwards. But the relative risk is the measure of treatment effect in a randomized trial. And it's basically just the ratio of events, right? Now, we've got two different kinds of events here. We've got oranges and apples, right? Now, this is the treatment group up here, and this is the placebo group down here, right? So there's 1, 2, 3, 4, 5, 6 events in the treated group, and 1, 2, 3, 4, 5, 6, 7, 8 events in the untreated group. So there's 6 over 8. That's the relative risk. But there are two kinds of events. There are events that are affected by the trial treatment, and there are events that are not affected by the trial treatment. Yeah? Now, the oranges are affected by the trial treatment. And so the relative risk for this cause of death is 0.5, right? So it's 2 divided by 4 is 0.5, right? The treatment has no effect on this other category of deaths, the apples. And so you say the same number of apples in both groups. So it's just, if you find the cause-specific endpoint, right? So tranexamic acid reduces bleeding. And it reduces bleeding on the day of the injury. So we give a course of tranexamic acid. That's only, it's a very short course. It's only 8 hours long. And the drug has a very short half-life. So the drug's completely eliminated after the first day. So there's no drug in the body after the first day. So say this is deaths on the first day due to bleeding, and these are deaths on subsequent days, right? So tranexamic acid reduces, say it reduces these deaths by a half, but has no effect on other deaths. The overall result is really diluted by these deaths that tranexamic acid doesn't have any effect on. Yeah? Do you get that? And the amount of dilution depends on how many of these. So if these apples went on and on and on and on, there'd be lots of dilution. Yeah? So if we have a long line of apples over here, this would get smaller and smaller and smaller, but that would still be there. It's not that the treatment is, it's not that the treatment's not having an effect. The treatment is having an effect, but it's being diluted by by causes of death that the treatment has no effect on. Yeah? So this is the CRASH 2 trial. This is our previous big trial. 20,000 bleeding trauma patients. What we found is that the bleeding deaths are all on the first day, right? These are days from randomization. So basically, these two are within 24 hours of randomization. So nearly all the bleeding deaths are on the first day. In head injury, you can't say what the patient died of. You can't tell if it's bleeding in the brain or some other thing that killed them. But let's presume that the effect of tranexamic acid is also on the first day. After all, the treatment's only in the body for the first day.
So I think relative risk analysis is kind of a regression analysis, the logit model. Okay.
Right. So this is the effect of tranexamic acid on the first day in the CRASH 2 trial, our previous trial, and the CRASH 3 trial, the head injury trial. Right? So there's a 20% reduction near enough in both. Remarkably homogeneous results, right? So we're seeing exactly the same, I think, biological effect in the CRASH 3 trial as we saw in the CRASH 2 trial. In the CRASH 2 trial, tranexamic acid reduced the risk of dying from bleeding on the first day. In the CRASH 3 trial, tranexamic acid reduced the risk of dying from bleeding on the first day, and by the same amount. This was our hypothesis. So why should the effect of tranexamic acid on bleeding death be any different in head injury? In fact, coming back to this null hypothesis, this p-value thing that everybody's very keen to slice into less than 0.05, more than 0.05. Behind any p-value, of course, there's a null hypothesis. You know this. So the null hypothesis is that there's no treatment effect. The risk of death in the two groups is the same. But I think we've got to ask, how reasonable is the null hypothesis? Bearing in mind that we know from a big trial of 20,000 patients that tranexamic acid reduces the risk of bleeding on the first day by 20%. See, I believe that the null hypothesis isn't the relevant hypothesis. That actually we shouldn't be comparing tranexamic acid with the null in head injury. We should be seeing, is it meaningfully different from what we found in the previous trial? I mean, they're both trauma trials. So, patients had an injury to the body, patients had an injury to the head. Shouldn't the null hypothesis be that, we'd expect similar treatment effects in the two situations? Conceptually, I think it's more sensible to think of the CRASH 3 trial as filling in a missing subgroup of the CRASH 2 trial. So the CRASH 2 trial had 20,000 patients. Some of them had head injuries, some of them didn't have injuries. The only thing they weren't in the trial were patients with isolated head injuries.
CRASH 2 is extracranial, CRASH 3 is intracranial.
CRASH 2, they had to have extracranial bleeding, but some of them also had head injuries. CRASH 3 was only head injuries. So I think these are best seen. This is a trial of tranexamic acid in trauma patients, and this is just a subgroup of this. And so the fact that we get remarkably homogeneous results is that, you know, that's what we should be asking ourselves. Are the results of the CRASH-3 trial meaningfully different, you know, from the results of the previous trial? So this is the effect on all-cause mortality within 24 hours of injury. So tranexamic acid reduces the risk of dying on the first day. But when you get to 28 days, a lot of that treatment benefit has been diluted out by causes that tranexamic acid cannot affect. So tranexamic acid affects bleeding on the first day, but it doesn't have an effect on pneumonia on day 15, or, you know, or sepsis, you know, severe sepsis on day 20. You know, it can't do anything about that.
So do this CRASH-2 is a subdivided group into subalcoholic hemorrhage and also the other hemorrhage of extracranial?
Our primary outcome was whether patients died of their head injuries. But the thing about head injuries is that when someone who has a head injury and dies, people just say they died of their head injury. But, you know, they may have died on the first day from raised intracranial pressure, from bleeding, or they could have died on day 28 from a pneumonia. So the effect, so these are deaths on the first day in extracranial injury. These are deaths on the first day in intracranial injury. And we got exactly the same effect on deaths on the first day, the bleeding deaths. And what we got is dilution towards the null by the apples. But because we have more apples in patients with head injury, we get more dilution towards the null. And in patients with mild to moderate head injury, you don't get so much dilution towards the null. So this is mild to moderate. So severe head injuries, you know, they're very high death rates. So you get this early treatment benefits completely diluted out by late deaths. But in mild head injury, it's not, because, you know, if you don't die of bleeding on day one, you don't die of anything else. But with severe head injury, if you don't die of bleeding on day one, you only live to die from something else the next day or the day after that.
Yes, I agree with you that these results are very consistent in CRASH-3 trial and among other trial in CRASH-2 and CRASH-3. Yes, I agree with that. That these are all subgroup analysis, and we are taught from Sato sensei and Fuka sensei that the results of subgroup analysis are just hypothesis generating, especially when the primary analysis is not significant. So can you say the results of these subgroup analysis are conclusive or just hypothesis generating?
I don't know. I think I think when you've got a body of results, what you try and do is try and understand. It's a sort of collection of information, and you try your best to understand it. That's how I approach it. And you know, it's this thing about, you know, I understand the need to avoid data-dependent analyses, and but there is important biological information in subgroup analyses as well, I think. And I think, you know, we want to learn from that.
Yeah.
I think you have to distinguish between the conclusion to be drawn from this single trial and also how to interpret the findings. And then the conclusion to be drawn from this single trial should follow at least the rules of the randomized control trial, which says unless you have p less than 0.05 for your predefined primary outcome, the trial is essentially negative. However, you can interpret that along with other evidence. And that is exactly what you are doing.
But where did this rule for randomized trials come from?
Well, FDA.
FDA. Is that true?
Well, originally from Fisher.
But did Fisher say less than 0.05 the treatment works and more than 0.05 the treatment doesn't work?
No, he didn't say that. He said that unless, well, let's forget about this 0.05 because I do essentially agree with this artificial dichotomization at 0.05, and I am basically for ditching out p values. However, the interpretation of a statistical trial should be guarded because in order to guard against inflated alpha values, that is the lessons we have learned through the history of conducted and misinterpreted clinical trials. But having said that, what you are trying to do with this subgroup analysis is, I think, essentially prediction model. You are saying that looking at the bigger picture can be diluted by some other insensitive groups. So you want to pick up sensitive groups which do respond, in this case, to taxanemic acid. And that is a prediction, subgroup analysis, and building a prediction model to run or to do stratified analysis. But the caveat there is that overfitting. Therefore, I think what you are trying to do should follow the rules of the building of the prediction models, in which you first build your model on the training set, and then try to validate that in an external sample. And if that prediction model, meaning that this works for this subgroup but not for that subgroup, is validated in an external.
I don't know whether I don't see where the prediction model is though in here. I feel it's just like you've got this collection of information, you've got this data, and you're trying to use your biological knowledge and your statistical knowledge to understand what's happening.
Well, that does not serve the clinical practices, because we want to know if the results apply to your next patients. And in order for the results or your biological understanding to be applicable to your next patient, you have to validate your prediction model or your subgroup analysis.
Oh, okay. All right. So, more results, no increase. I mean, we're worried about, obviously you're worried about if the treatment improves outcome. If the treatment reduces the risk of dying, perhaps it increases the risk of disability. Well, it didn't. There's no evidence of an increase in disability in the survivors. And no evidence of disability in the survivors again. And then you might be worried about side effects, and there aren't any side effects. Whether you give it, whenever you give the treatment, there was no increase in any of the side effects that we collected. So you might think, well, treatment reduces bleeding, might increase the risk of vascular occlusive events, but it didn't. So the risk of so now we've got a situation. We've got a treatment. It's an inexpensive treatment. It seems safe. Japanese women take it every day to whiten their skin. I don't know if you know this, but a lot of Japanese women like to have skin that looks like mine. And they take tranexamic acid. One of its side effects, one of its few side effects, is that it tends to whiten the skin. And so lots of Japanese women take a gram of 750 milligrams of tranexamic acid every day for this purpose. It's sold over the counter in Japan as a beauty product. But anyway, that's not science, that's just an anecdote.
I have a question as a clinician. Pulmonary embolism is really underdiagnosed in Japan.
Yeah.
But in this study, how is kind of
How
sensitivity, general sensitivity to detect pulmonary embolism?
Well, what we try and do in clinical trials is not have very sensitive diagnosis, but we have very specific diagnosis. So we only want people to record a pulmonary embolism if they're sure it is. Now the reason we do that is that if you have high specificity, there's no bias. I mean, you might miss some cases, but the danger is of including cases, calling something a pulmonary embolism that's not a pulmonary embolism. And so we avoid that by having high specificity. And so but we don't find much evidence, we don't find any evidence here that tranexamic acid increases the risk of pulmonary embolism. So, I was saying, we've got a treatment that's very cheap. It doesn't seem to have any side effects.
And also the stroke, they don't say stroke is including infarction and also hemorrhage.
Yeah, this is clinical stroke. Yeah, yeah. So it's an inexpensive treatment. It doesn't increase the risk of, it doesn't seem to have any obvious side effects. It reduces the risk of death by about 10%, but it could be much more. Could be as much as 20% reduction in the risk of death, or there could be very little reduction in the risk of death. But the best estimate is a 10% reduction in the risk of death. I think, well, why wouldn't you want this treatment? Why wouldn't you want it? So, okay, there's a risk, and there's always a risk that it's a false positive, right? That you've falsely concluded that the treatment's effective when it's not. Now, there's always the risk, but you might say, okay, the risk here, if you falsely conclude the treatment is effective, then you've given someone a cheap treatment with no obvious side effects. If you falsely conclude that the treatment is not effective, then you've denied somebody a 10% risk, 10% reduction in the risk of death. I think, well, okay, now I have to weigh all of these things together. Which is worse? I know what I would want. If a relative of mine had a head injury, I would want them to get tranexamic acid as soon as possible, preferably at the scene of the injury. That's what I would want, because I was talking to neurosurgeons about this, and they were saying, but they were going this 0.05 thing, and I said, well, look, they open people's head up, they drill holes in people's head and take blood out. And I said, is there any evidence for randomized trials for that? No. So there's no evidence for any of the things that most doctors do to patients. And here we've got, I think we've got so much more evidence. So this is the results of the CRASH-2 and the CRASH-3 trial on head injury death death within the first 24 hours. And low and middle income countries, you get slightly, people often say to me, because we do global trials, they say, oh, you're doing them in poor countries. Well, those don't apply to wealthy countries like United States and Japan, but they do apply. In fact, the treatment effects in high income countries are slightly bigger. It's not statistically significantly heterogeneous, but it's about the same. So